Hi, good afternoon, good night. It is good afternoon for me in Peru. So we are super excited for today because we have a very special VMR. It is guided by Dr. Andy Kowalski. And today we have a case presenter whose name is Pablo. And I'm so super excited for today's case. This is our first nephrology VMR, and I hope you all enjoy the session. So maybe Dr. Andy Kowalski can present himself.
Sure. Thank you so very much. I'm Andy Kowalski. I am a nephrologist in the suburbs of Chicago. I work in a private group, and I am affiliated with a hospital that has residents in training. I do a lot of teaching for the residents, for the med students, and even at the fellow level when I go back to my, well, I've done a couple of online presentations at my old fellowship stomping ground. So happy to be here, and I'm happy to share some of my thoughts. So this is gonna be fun.
Pablo, do you want to say hi and introduce yourself, and then we can get started?
Of course. Hi, everyone. My name is Pablo. I am a second year nephrology fellow at Northwestern. Actually, Andy Kowalski was my mentor. Awesome guy. So yeah, well, we're going to talk about the case of nephrology hypertension. I think we're going to talk a little bit more of hypertension this time. So welcome, everyone, and thank you for being here.
Okay, and we've asked Franco to discuss the case as well. So Franco, do you want to introduce yourself? He's also going to be doing teaching points. So he will be sharing wisdom and then recording his wisdom down.
Hi, everybody. I'm Franco. For the ones that don't know me, I am a physician from Peru, currently participating in the match, aspiring to be an internal medicine doctor. So I hope we have a lot of fun today.
Okay, we could get the board up to get started.
All right, so is it okay to start now? Okay, good. Okay, alrighty. So this is a patient that we saw in clinic that is a female. She's 30 years old, and she came because of hard to control hypertension. When we saw her the first time, she was on, I'm gonna open my screen right now. So she was on nifedipine 60 milligrams twice a day, hydrochlorothiazide 25 milligrams once a day, and labetalol 100 milligrams twice a day. The other thought that she wanted to share with us is that she wanted to become pregnant, and because of this elevated blood pressure, she was pretty concerned about this. She was seen by her primary care physician on a routine examination, given that she wanted to become pregnant, and her primary noted that her blood pressure was 180 over 100 on her office. And then what the primary did is just, of course, this was her first time knowing that her blood pressure was this high. She never heard anything about that before. What she did, what the primary care physician did is send her home to take her blood pressures routinely twice a day for a couple of days. At that time, no symptoms were associated. And at home, she noticed that her blood pressure was persistently 180s or 200s over 100s without any associated symptoms. So the primary care doctor sent her to DED. And DED, she was given labetalol. They noticed some chronic changes on her EKG, showing that she had chronic hypertension. She had LVH changes on her EKG. And they run a BMP and some just regular labs, and they didn't notice any in particular beta potassium of 3.2 with a bicarb of 26, and then she was discharged on nifedipine. She went back to her PCP's office, and the PCP noted that her blood pressure was persistently high. And because of that, he added the medications that we just talked about, the labetalol and the hydrochlorothiazide.
Okay, should I start, Marie? It's okay. Oh, I think you're mute.
Yeah, Franco, we would love to hear your thoughts.
Okay, perfect. So what I think is that this patient has been already, I get that she was already hypertense. So right now we are in the setting course that it is a patient that it has an uncontrolled hypertension. So beside that she's on many antihypertensives, I think that the main problem should be, is this like a completely normal hypertension or not? So what I would definitely think is there any anatomical defect on the vasculature of the kidneys, in order to think if it is like something like a bilateral stenosis of the renal arteries that is not controlling their hypertension, if it is something that it's increasing the adrenal tone, maybe like sort of like pheochromocytoma. I don't know if this patient is the first time like she was trying to get pregnant. Maybe she has been already hypertense in a previous pregnancy, so that could be also a good thing to know. The other thing that I can feel is that, well, the potassium is know that there's nothing else in the potassium, so there could be like, I don't know if there could be an aldosterone picture here also. I don't know if another thing that could be is like a concomitant use of drugs, maybe cocaine, that can be driving this uncontrolled hypertension. That's anything I could add there. Dr. Kowalski?
Yeah, I was curious, why did you jump to thinking about vascular disease right away? What was your thought process?
Well, because this patient has already been on hypertensives, so I thought that being something that if we are giving the medication and it is not controlling, the renal artery should be like, could be like vasoconstricted. And if this is an anatomical defect, the solution will be not only on the meds. It is like a vascular problem that we need to put something mechanic over there. That is not the solution. That was my way of thought.
Yeah, no, absolutely. My first thing was she's 30. You know, there's no reason why she should have essential hypertension at the age of 30. It's usually related to something else. Pablo, I had a question for you too. Did anyone in the ED do a drug workup?
None of the ED. It was done at her primary care's doctor office in the follow-up visit, and it was negative.
Okay. Okay. And then the only labs we have is the potassium of 3.2 and 26 for the bicarb that's relevant. So I'm assuming the BU and creatinine is normal.
Yes.
Okay. And then she went to her primary not on any antihypertensives, and then she was placed on them after the fact. And those were the three.
That is correct. This is the very first time she ever hears that she has hypertension.
Okay. Perfect. Perfect. All right, great.
Alrighty. So going ahead with this, she doesn't have any past medical history at all. She's never tried to get pregnant. She's never had any miscarriages. She doesn't have history of diabetes. She doesn't have any admissions to the hospitals or visits to the ED, but the one that we just talked about. She is only taking the medications that we talked about. She does not use any type of caffeine products. So this is very important to ask, because sometimes we ask how many cups of coffee you drink, and we found out that they drink Red Bulls or any of those caffeinated drinks, right? Or even gum. So no caffeinated products. She doesn't smoke. She doesn't drink or use any type of drugs. Her family history, her mother and father have hypertension. They are around their 60s. There's no history of kidney diseases in the family. There's no history of cancer in the family. There's no history of any hypokalemia in the family. That's also something important to mention. And there's no history of anything else, no diabetes in there. And she is not allergic to any medications. So I think no major changes from the this past medical history doesn't really concern us at all.
What are some of the thought processes, Franco, that you have based on this information?
Well, yeah, now that I got the picture a little better, because the first article I got that she was already hypertensive, so that was my mistake. Well, the family history could be important if we are thinking about like a familial hypertension setting, like this is her mother, her father, maybe there is a strong genetic component there that could be undergoing that way. But I would expect like other some endocrinopathies, if we are thinking about a MEN1 or a MEN2 feature. Pretty much that would be the thought process that I could have until here. Dr. Andy?
No, I'm kind of interested to see, more of the workup. I have my own set of questions. I love some of the chat that's going on. I want to like hammer down on some of these too. These are great. But yeah, I think waiting for the exam and the initial, I guess, blast of labs is gonna kind of seal the deal for me.
What would you be looking for on exam, and what labs would you be thinking about sending in this case?
Are you asking me or are you asking
Yeah, I was asking you kind of like what
Okay.
would be some of the things you would be looking for?
So I'm assuming unless she has like cushingoid features or whatnot, the exam is going to be completely normal. The big thing that I want to see is going with the labs. It's amazing what you can get with the lab results. And the nice thing is that she's not on anything that's going to alter renin aldo, which is great. So my first thing would be, I definitely want to see a renin aldo ratio. I wouldn't mind seeing a 24-hour cortisol. I wouldn't mind seeing a cortisol cortisone ratio. If we can send out an ACTH, I know some places do, some places don't. I see a lot of validity in that as well. And definitely imaging. I mean, if we're thinking about any sort of renal vascular problems, I mean, she's young, she doesn't have any family history, but FMD is a big thing that pops into my mind first. And then anything else that could happen. I mean, she's a little young for a vasculitis, doesn't mean it can't happen. So seeing a UA and seeing how active or not active would be big for me.
Awesome. So we're going to have two different set of labs, the ones that the primary care sent and the ones that we sent, because they have some particularities that on their timing, as we're going to speak. So she was on her vitals, she was afebrile, her heart rate was around 70s, 80s. Her blood pressure was 200s over 100, and her respiratory pattern was okay. Both her oxygenation as well. Her physical exam, just gonna go ahead and tell you guys that there was no bruit on her abdomen. There was no bruit on her femorals or in any other vessels that we could hear. She didn't have any edema. She didn't have difference in pulses. She didn't have any difference in temperatures on her extremities. The only thing is what her BMI was a little bit elevated, was around 28, 29. And she did have chronic changes on her retinal arteries, meaning that she was chronically hypertensive. Though besides that, all of her physical was okay, as we were already thinking of.
Well, yeah, I would think that the main feature is that the previous EKG consisted with left ventricle hypertrophy, and the fundoscopy with changes point that this has been going on for a pretty while. Not sure if the VMI could be like a feature of an endocrinopathy that could be adding to this problem. I'm really glad that there are no brutes over there that could point like into the way that there is a renovascular problem, but that would be only if this is like a big stenosis or something like that. We could find out on physical examination. Otherwise, I think we are heading to also a complementary ultrasound about it. Some of the labs that we can find.
Perfect. Okay, so anything you want to add, Adi, on the physical? That, I mean, there were no cushingoid fascias or anything like that.
Yeah, I wasn't expecting much to come from the exam, to be honest with you. But I kind of echo what Franco was saying, that considering there was something found, this has been going on for a while, which makes me slightly change my differential a little bit more towards a developmental issue, but we'll see what happens.
Okay. Are you ready for the labs, Franco or Kara? Okay.
Yes.
So her WBC count was unremarkable. All her numbers were okay, as well as her hemoglobin, hematocrit, and platelets that were within normal levels. Her sodium was 138. And this is, I'm gonna give you two set of labs, okay? This is I'm telling you the primary care doctor's labs. Was 3.2, her potassium. Her chloride was 108. Her bicarb was 27. BUN was 16, and creatinine was 0.8. Her glucose was 98, fasting. Calcium was 8.4. Phosphorus 3.8, magnesium 2.2. Something important to always assess when we have hypokalemia. Her albumin was within normal limits as well, and her LFTs as well. This one, I'm just trying to save some time. The primary at the time did an EKG that showed LVH, as I said before, and her chest X-ray didn't show any abnormalities on the lung fields or any cardiomegaly or anything like that. And then at that time, the primary care doctor ordered an aldosterone and renin levels, and also ordered some metanephrines, and also ordered vascular ultrasound of the renal arteries. And I'm going to tell you the levels right now. If you bear with me 1 second. If you have any questions, Andy, or anything you want to ask me, I can do.
Did she have any complaints of anything that would fit Theo, or any sort of like diarrheal illness?
No, not at all. No associated symptoms with this high blood pressure, to be honest. She never had any
doom, no like jitteriness that comes and goes, nothing like that.
No, she didn't have any of these type of episodic symptoms of sweatiness, headaches, palpitations, waking up in the middle of the night. She didn't have any exercise intolerance. She's not been losing weight, no diarrhea, nothing like that. So her renin was, hold on. All right, so 1.4, and also her aldosterone was 11. Okay, and this was taken already on the medications that we said on the labetalol, on the nifedipine, and on the hydrochlorothiazide, and when her potassium was low. So this is what we got from the PCP. And her, I think we can skip the renal vascular ultrasound for now. We can mention it in a little bit.
Well, the renin, what is the normal value for renin and aldosterone, Pablo, for your labs, for your laboratory?
It was normal. Both of the values were normal.
Okay.
The ratio was like 7.9 or something.
Yeah, okay, well, I would have expect a little more, if this is what's a problem of primary aldosteronism, I would expect that differently, that the renin could be low and the aldosterone high, so that would be a primary aldosteronism. But it is important to point out that, correct me if I hear wrong, Pablo, those labs were taken with the patient taking the medications, right? The labetalol or the nifedipine, or it was before that? Because I know that.
Yeah, it was taken when the patient was on a calcium channel blocker, on a beta blocker, and on a thiazide diuretic.
I think that usually you have to withdraw some of those meds before taking those exams. I don't know if that's correct, Dr. Kowalski, but we could be also having a false negative over there because of that. I'm not quite sure about it. Otherwise, if these are the true values, I will definitely incline to a renovascular problem.
One more thing, sorry, I forgot. Her thyroid profile was normal as well, and her metanephrines in urine were unremarkable.
Okay, so that would be
and her drug screening test was negative. Again.
Okay.
And did they do the cortisol and cortisone ratio as well, or no?
Not at that time. When we did it, it was normal.
Oh, okay.
So what are your thoughts, Dr. Kowalski?
I'm waiting on the imaging at this point. So labetalol, does it affect renin secretion or not? I haven't seen it when I've done these tests in my patients. Like folks that are going to be hyperaldo are still going to be hyperaldo. They're not on any ACEs. They're not on any aldo blockade. So I'm actually quite fine with what was done. And the only thing that would potentially be skewed is how high the renin would be or how low the renin would be. And I would assume that the aldo level will be significantly higher. So I'm not too hung up on this right now. I do want to see the imaging though. That's really interesting.
Mm-hmm. Mm-hmm. Yes, as Andy's saying, when you have a renin and aldo level, you should be concerned if they were taken under either a renin blocker, an ACE, or an ARB, right? Or if the patient is taking a spironolactone medication, so amiloride, anything that blocks aldosterone. But the only thing that we, of course, you guys are gonna ask me, why do we repeat the labs? Is first of all, her potassium was not normal. So whenever you wanna work up hyperaldo, that's the thought that we had at the time, her potassium has to be supplemented and normalized. And then most of the times when we have this type of consults, we see that the technique that the lab does to collect the aldosterone and renin levels are wrong most of the times, and the patient is not explained what they should do before taking the exam. So and the other reason is the imaging that I'm gonna tell you guys right now. So she did have severe renal arterial stenosis on her right renal artery. Her left artery was the velocities, there was no any resistance or anything like that. So it was a problem of the right renal artery. Okay, so with that being said, we gave her potassium pills, and she came to us again with normal potassium levels. Her potassium, when we repeated the aldo and the renin, where her potassium was 3.8 and her renin and aldo at that time were pretty elevated, and I'm gonna tell you the values right now. Her renin was 33 and her aldosterone was 23, which is of course very, very high. Yes, I know it's a big jump. It's a big jump. What we tell our patients when they have to take the aldo and renin is that they should follow a regular diet. They should not, because sometimes when the patients think, oh, I'm gonna get some labs, they stop eating salt, right? They stop drinking water, they stop doing the regular things, and that changes things. So you have to tell them, just have your regular diet. Don't change any salt in your diet. Don't change any potassium in your diet. And then they should not be sitting more than 15 to 20 minutes in the chair when you take the lab, because supine and sitting position might change the hormonal levels, even though it might be a stenosis causing them. The other thing is that the technique of getting the blood sample, it should be frozen almost immediately after it has been centrifuged. Otherwise, the sample can be misleading. And we have seen multiple times that we get these consults, and when we repeat the renin and aldo, they are elevated. So potassium, diet, and lab technique. And then the cortisol level that you were asking, they was okay, the ACTH.
Pablo, would you share what the upper limit of normal is on the renin and aldo?
Yes. If you give me a couple of minutes, I can look for the exact value that our lab has. In the meanwhile, someone, maybe Frank or Dr. Kowalski, can mention anything.
Yeah, I want to say it's less than 3, but don't quote me on that.
Yeah, sometimes it changes. I don't have that in the top of my mind, so give me 1 second.
So how would y'all interpret these labs?
I'm sorry, say that again.
How would you all interpret these labs?
So on this repeat, I mean, right off the bat, like renin jumps out at me. So as soon as I see an elevated renin and there's nothing they're not on any aldo blockade or whatnot, then it's all delivery to the kidney, right? Kidney doesn't sense any blood flow, then whatever's being filtered, by the time you get to the macula densa, there's nothing there. Everything's going to be upregulated. So to me, this is just seeing this renin level. It's either a renin secreting tumor, which are extremely rare, or it's some sort of delivery to the kidney. Those would be the first 2 things that I would jump after.
Right.
Did they do an angio?
Yes, we did a couple more things as a workup of the following disease. I'm opening the system so I can tell you what the values, exact normal ranges are.
So what I found in our system, which again, it differs from place to place, is it's one upper limit is 4.7, another one is 5.5 for renin. But that's my institution, so I don't know.
So aldosterone is so here they tell you between the timing of the days, just because of the cycle of the secretion of the hormone. So, but usually it's between 3 and 15. That's the aldo, and the renin it should be between 0.2 and 5. So extremely high.
Mm-hmm. Let's get to the angio. I'm excited.
Okay. Can I share my screen? Because I think it would be.
You can.
Yeah. Okay. All right. Let me close Epic so you don't see any information. Alrighty. So I'm gonna share with you guys. All right, so we did a CTangio, okay? A couple of things there is, even though you highly suspect that you have a stenosis and you do an ultrasound and the ultrasound is negative, you still have to do a CTangiogram, because sometimes the ultrasound can miss things because it's just a technical issue, right? It's a technical exam. So can you see it here? Can you see my screen?
Yes.
Okay.
मैंने देखना है, but मैं भी टेड लासो देख रहा हूँ.
All right, so this is a reconstructed 3D angio. And I don't know if Andy, you want to mention something here, or I just go ahead and mention and tell you guys that here in the renal artery, the right renal artery, there's a pretty significant stenosis, right? That you guys are going to be able to see it better here. Right, and the report was mentioned that she had a 80% stenosis on the CTangiogram. Okay. All right. As part of our protocol, when we face this type of patients, we do a whole CT angiogram just to try to see if there's any other irregularities in the main arterial system. So we do a brain, we do a neck, we do a chest, we do an abdomen, right, and femoral, of course. And there were no other type of stenosis. The only thing that we saw is that her right hepatic artery might have actually did have some irregularities. All right, I'm going to stop sharing. All right, anything else you would like to see?
So there were
Oh,
sorry.
At 80%
Go ahead.
stenosis. Oh, sorry, Franco. I'm sorry.
No. Go ahead, doctor.
So they said that it was up to 80% stenosed, or they're like, I mean, it's all visual interpretation, anyways. But
Right.
Okay.
Yes. So what's 80% stenosis on the right renal artery?
Okay.
Franco, you wanted to say something?
Yeah, so just to clarify, the abdominal CT has some irregularities, right? The hepatic vasculature has some abnormalities.
Yes.
So
Right.
I think this would be like, if there is something like different like abnormalities in the vessel, I would definitely think like a vasculopathy, like or less that, like something that is messing up with the collagen, or if this is some kind of FMD, or if this is some kind of SAM that could be altered on those other branches, right? There wasn't any bruits in the neck, right?
Okay. Sorry, so, no, and then the CT angiogram didn't show any stenosis.
Okay, so I think we are like, the end of the case is like, yeah, the hypertension was due to a vascular problem, and it is on the edge if this is something isolated or if this is something systemic, right?
Mm-hmm. Yes, and you brought an important point. I actually forgot to give you guys the urinalysis, and it was a pretty bland urinalysis. Didn't show any RBCs, no protein, no casts or anything like that, which at this point will go against more active disease, inflammatory disease.
Great. Dr. Kowalski, something that you want to share about the case?
Yeah, I'm just kind of curious, like, why would somebody so young have renal artery stenosis? Like, that's interesting. I mean, there's no systemic anything, right? She doesn't have lupus. She doesn't have any signs of anything that Franco mentioned, right? No FMD, no Ehlers-Danlos, like none of those?
No. I mean, there was no concerns for any Ehlers-Danlos or anything like that.
Wow. What I think is really interesting is that we're getting a lot of comments about astral versus choral and all that. So I'm kind of curious what you guys did and which recommendation, or I should say, what did you guys do? Unless I'm jumping the gun on this one.
So at that point, we did start her on amiloride, trying to block her aldosterone. And her blood pressure did improve, okay, but she was still around 140s, 150s, and she was already on 4 antihypertensive medications, right? And the big thing on her is that she wanted to get pregnant, right? That was her life's dream, correct?
Mhm.
So of course we couldn't have her on so many medications if she wanted that, right? So what I think Bansal is asking asking a pretty good question. He's asking, what are the antihypertensive medications that I prefer on a renal artery stenosis? Yeah, so we put her on. We actually also changed her calcium channel blocker for an ARB because that's just pathophysiology. That's why you treat renal artery stenosis, and I'm going to show you a slide that I also have about that. Just one second. Which comes to a model that Dr. Kowalski's mentor loves. Hold on.
Ain't that the truth?
Okay, I want to share it for 1 second. This model. All right. So whenever you have unilateral, you're gonna have increase on renin, increase in angio, increase in aldosterone, and your treatment has to be directed to block all of those, right? And that's why you give basically any type of renin aldosterone blocker. It could be an ARB, it could be an ACE, it could be an aldosterone blocker, as we're already doing, right? But she was still hypertensive, correct? And she couldn't get pregnant with these medications. So what we did at that time, we talked to IR. We told her, we think that we should talk to IR, interventional radiology, and see if we can fix this, as Franco was mentioning in the VMR case. If there's something mechanical we can fix, right? So we had a meeting with IR. We had a meeting with the patient and the family, and told her, we can fix this, right? But there's a possibility that this can recur, not in that area itself, but some other areas on the kidney as well. So that's what we did. We did talk to IR. Let me show you what the IR findings were. So this was not an 80% stenosis. This was 95% stenosis, if you can see it here. Right? And I think sorry?
I said, I'm surprised Andy Contrast got through that.
Yeah, right. So maybe you can explain the picture better than I can, since it's your field of expertise.
No, I mean, I would say it's definitely a north of 90 degrees, 90% stenotic. I mean, that's quite impressive. And just to get that angio catheter in there is even more impressive. But there's no other, beads on a string or, rosary bead kind of analogy anywhere there. So it's just like a single solitary lesion is what I see. Now, right. I have my own thought on this, but I kind of want to finish hearing what you guys did and what IR did.
Yeah, so we talked to IR and they opened the lesion, right? And you can see how the lesion improved after they opened it, right? Here in the left and the right, you can see previously to the procedure, and then how they did a plastic, right? And after that, her blood pressure, of course, resolved. I mean, her hypertension resolved. She is now off medications, and she is her potassium normalized, her aldosterone and renin levels normalized, as you can see here. The left part is the most recent one, okay? And her aldosterone levels also normalized, and her renin levels also normalized. As I said, the left part of your screen is the most recent labs. But yeah, as Dr. Kowalski was mentioning, it's very atypical because I think at this point we were thinking that we were going to face a fibromuscular dysplasia. I think we agree on that, correct? So usually, as Andy's saying, we will face more irregularities rather than one lesion, right? We have multifocal lesions, right? So But since this patient was young, she's a female, she was 30s. This was the most likely diagnosis, and also she had some irregularities in the hepatic vasculature. Right? So that's what we did.
This is awesome. So I'm kind of happy they went ahead and opened it. So a couple of things went through my head when we were going over this. Like one, you know, it's the big argument, right, with Astral and with Coral. Like, do you open it up or do you put them on medication? Because technically in atherosclerotic disease, the change in medication is negligible, right? I think the average is like what, you come off like half a pill or a pill, you know, at most. But in FMD, that's the only time where opening it up is beneficial because you can have almost complete resolution of everything. So my thing is, before knowing even more of it, I would have decided to push to get that opened just because of her age and the high likelihood that this is mostly FMD as opposed to atherosclerotic disease. And I'm really happy that they did that. So yeah, so if you see this and it opens up and everything resolves, that's FMD. That's great.
Right. So if you, Franco, I don't know if you have anything to say, and maybe we can share with you some slides that I have of the case.
No, I don't think we have anything to add there. Oh, I think, no, yeah, anything to add.
Someone asked a very important question, and that's something that you always have to discuss with your patient. And they will ask, and you have to tell them that, right? This might recur. Not in that specific area where you did the plasty, right? But it can recur in the left artery. It can recur in the one of the carotids, right? It can recur anywhere. So you always have to do a full workup, make sure that there's no stenosis yet. So you have a kind of a baseline imaging, and then you start following the patients every year, right? The only thing I wanted to mention you before, where's this? Maybe you can share my screen again. Here it is. So most of the times, 95% of 90% of the times, you're gonna see the video appearance of the arteries, which Dr. Kowalski was mentioning. But between 5 to 10%, you're gonna see a unifocal disease. So if it's this disease presents usually in young females, usually they tell you that people that smoke will have a more rapidly progression of the disease. You'll probably gonna find or not an abdominal bruit, and you have to rule out that there are other FMD disease in the body, right? As Dr. Kowalski was saying, in these patients, angioplasty is a treatment because it's not an atherosclerotic disease, right? So you can actually treat these patients with this. So yeah, and now she, as I said, she's finally out of her medications, and she's hopefully getting pregnant soon.
That's awesome. I had another thought that popped in my head too. So I have to go back and look at this because I'm not 100% sure, but I think I remember reading, and it was either Astral or Coral. I think it was Astral, where there was a trend towards benefit if the stenotic lesion was greater than 80%.
Right.
And that makes sense too, right? I mean, so if you're between, you know, usually you don't plasty anything, at least from the interventional perspective, unless it's north of 50, right? And then, so between like 50 and 80, are you really going to get that much benefit? And it's like, I don't know. But I mean, if you're pinching it off so much where you're getting a trickle of blood, I would argue that opening it up will give you more benefit than just putting them on more meds.
Right. Right. And something to just, as Andy's saying, the flow to the kidney is not always directly related to the grade of stenosis. So you can have a high grade lesion, I don't know, like 80% sometimes, and your flow to the kidney is gonna be preserved, right? But you start seeing the changes as this slide is showing around 82% or 80%, right? Not in all of the patients, but that's what you see. right? Someone did ask about licorice, which came, I think, in the New England a couple months ago. This is a very fascinating topic. Hypertension, hypokalemia, and metabolic alkalosis. And this is a very nice chart that I always use. Okay, so if you guys can look at it and share with you. But yes, so always measure your renin aldo, but make sure that the patient is not on an ACE or an ARB and their potassium levels are okay. All right. If the renin is high, your diagnosis is going to be a little bit easier because only a couple of things gonna give you high renin and high aldo, right? Either a renin producing tumor, which is very unusual, which is going to be around the kidney as well, or renovascular hypertension, like coarctation of the aorta can give you that, or renal stenosis can give you that as well. But if your renin is low and you are sure that the patient is on an ACE or an ARB or not an spironolactone or amiloride or whatever is blocking the aldosterone, measure aldo, correct? And if it's high, your diagnosis is pretty kind of straightforward. It's primary hyperaldo, and then we can talk about this some other time. You have to do a salt loading test, you have to CT at the adrenals, and you have to go and collect the venous sample from the adrenals, from the IVC to compare, and then treat if for whatever the results you get. But the aldosterone is low, which is kind of, to be honest, very uncommon, especially in our adult population. You can have Cushing's syndrome, congenital adrenal hyperplasia, Little syndrome, and licorice, which is also very uncommon. I haven't seen one.
Licorice is also transient, if I'm not mistaken. Like you have to be eating it constantly.
Oh yes, yeah. 24/7.
Yeah. So, no, but that's very interesting. It's a really interesting case. And I think also going back to the renal artery stenosis slide that you showed, I think it also depends on which artery, right? If it's one of the main branches, yeah. But if it's one of the offshoots, probably not going to be that big of a deal.
Right. Yeah.
You know, but I think that's just self-explanatory.
Yeah. Yeah. The other bullet point I wanted to mention is that we get a lot of consults saying resistant hypertension, right? And most of the times, I will say 80% of the times, they're not resistant hypertension. It's quoted wrongly. One, the patients, and I have the definitions here. All right, so this is a definition that has been there for a while already. I think there's more recent one. The most recent was from 2015, but it's not really changed. So you have to have a diuretic, so 3 medications: a diuretic, which can be chlorthalidone, hydrochlorothiazide, Lasix, but it has to be maxed at this dose, okay? And 2 other drugs that are usually, it can be either an ACE, an ARB, or calcium channel blocker, or a beta blocker as well. Beta blockers are not a great antihypertensive, to be honest, but, and they have to be maxed as well, correct? And you have to make sure that the patient is having a low salt diet under this definition, because most of the patients will not be on this low salt diet, and the ACEs, the ARBs are not gonna be that effective. Once you make sure that this diagnosis is accurate, then you go ahead and do your work, right? There's other entity called refractory hypertension that the patient has to be maxed on 5 medications and has to be seen by a hypertensive specialist. That's my last bullet point that I wanted to share.
I would just add to that too. And it would just be a subset to that, where make sure that the medications are of opposing classes, right? So if you're just on like hydralazine and then you're on, amlodipine, why not? You should have something on opposing ends, right? You should have like a vasodilator, then you should have an ACE blockade, or you should have a diuretic, and just something so you're hitting it from multiple angles. This is great. This is a lot of fun. I like it. Good case.
Thank you so much, Franco, Pablo, for just presenting an awesome case, and Andy, really enjoyed it, learned a ton, and I am excited to wrap things up with Kira sharing some of the awesome teaching points that were discussed.
Of course. Thank you so much, Pablo, for presenting this amazing case. Actually, I remember Franco present a previous case of a female, a young female with a new myocardial infarction, I believe, and she was found to have fibromuscular dysplasia, and this was like my first case listening about fibromuscular dysplasia, like in a focal way and not multifocal artery compromise. So just to resume some teaching points, we found that this was a female with uncontrolled hypertension under many medications for control her hypertension. So we started with Franco and he told us brilliantly that when we have an uncontrolled hypertension, we can think about vascular diseases, maybe if there is a bilateral stenosis or unilateral stenosis. Also, we have to think about some vasculitis, fibromuscular dysplasia, or Ehlers-Danlos. Also, we have to think about that maybe this patient has an uncontrolled hypertension due to a pheochromocytoma, like in the setting of MEN1 or MEN2. Also, we have to ask on her family history if she's consuming some medications or some illicit drugs like cocaine, and many other diseases like hyperaldosteronism, just in this case. So we found that this patient had low potassium. So with that being said, we were thinking about hyperaldosteronism because she had hypertension and hypokalemia. And then we also found that this patient had high renin. So Dr. Andy told us that why is this patient having high renin? So when we have that information, is that maybe there is a renin secreting tumor, or maybe there is some low or some high delivery to the kidney that is making the kidney produce high renin. For example, maybe low blood pressure that is not in this case, or low sodium delivery to the kidney making produce it high renin, or maybe there is a high sympathetic tone making the kidney produce this renin. So finally, more additional workup revealed not remarkable labs. However, renin and aldosterone were increased in the second setting of labs, and an image revealed that this patient had severe stenosis up to 95%. So the big important question was, why is this young patient has renal artery stenosis? So this was a female with uncontrolled hypertension and some irregularities, not only in the renal artery, but she had some irregularities on the hepatic artery. So that increased the probability for fibromuscular dysplasia, even though fibromuscular dysplasia should be multifocal, more than focal. We found here that she probably had 2 vessels compromised. So at the end, what we needed to finally diagnose her with fibromuscular dysplasia was that when the physicians opened her artery, the symptoms resolved, as in this case. So this was an amazing case for fibromuscular dysplasia. Thank you so much, Paolo and Dr. Andy and Franco, for this brilliant and expert discussion.
Thanks so much, everyone. Have a good night.
Yeah, this was great. Thanks for having me on.
Thank you. Have a good night.